Yeah, so just before we begin, thank you everybody today for joining us for this seminar. I'd like to acknowledge and celebrate the First Nations people on whose traditional lands we meet and work. I would specifically like to acknowledge the Bidjigal people that are the traditional custodians of the land on which the UNSW Kensington campus stands. And I would also like to pay my respects to the elders, both past and present, and extend that respect to other Aboriginal and Torres Strait Islanders who are present here today. So I'm Dr. Kira Smith. I'm a Senior Research Fellow here at the Social Policy Research Centre, and I'll be hosting today's seminar. And today we're delighted to have Professor Karen Fisher, Dr. Peri O'Shea, Dr. Gianfranco Giuntoli, and Mr. Fred Zmudzki, who will be presenting on the HASI CLS New South Wales evaluations outcome, looking at community mental health and housing. So we've actually got 4 presenters, and you're lucky you get 4 for the price of 1 today. All 4 are actually going to be speaking, which is wonderful. So we have Karen Fisher, who's a professor at the Social Policy Research Centre, and her research interests are the organisation of social services in Australia and China, disability and mental health policy, inclusive research and evaluation, and social policy processes. We also have Dr. Peri O'Shea, who is a lived experience researcher who specialises in participatory qualitative research with people with mental health challenges, drawing on her lived experience as both a consumer and carer, and her significant experience in consumer-led mental health policy reform. Then we have Dr. Gianfranco Giuntoli, who is a research fellow at the Social Policy Research Centre. His research interests lie in the social study of health and illness, with particular focus on the connections between well-being, poverty and employment transitions, and how social and policy factors affect people's interpersonal and interpersonal experiences of well-being and their resilience. And then finally, we have Dr. Fred Zmudzki, who is a senior health economist and policy analyst with over 20 years experience across a wide range of projects in Australia, Asia and Europe, covering industry, academic research and government. Fred's experience is particularly focused on health economics modelling and evaluation, with an emphasis on social policy and program evaluation. So all 4 presenters are actually going to be speaking today, so they'll take a few slides each. And so what they'll speak for around 40 to 45 minutes, and then that will be followed by a Q&A session. So we'll have time to ask the presenters some questions directly, but if you like, you can also include these questions in the chat during their discussion, and depending on how things go, we'll either just leave them all to the end, or we'll just see if it seems relevant to address them in the interview or in the interview during the seminar. But Karen, you can let me know if there's any questions you want to answer during your talk. So everybody, if you could just make sure that you have turned off your sound and that you've turned off your cameras, just to aid this presentation going smoothly. And also, we're having some trouble with the CC captions, closed captions today. So unfortunately, they don't seem to be working. So we're very sorry about that to anybody who's affected by that. So please, if you're having trouble, please get in contact with us afterwards, and hopefully we'll be able to find a way that you can actually listen to everything that was presented today. So Karen, I'll hand over to you. So thank you.
Thanks very much, Kira. So I'm Karen Fisher. I'm the lead of this evaluation, but you can see from the first slide here that this is part of an enormous team. The CLS HASI evaluation and the program itself and the people that we work with were many and numerous over many years. 4 of us are presenting today, but I hope that some of the other people who have been involved are also online. If you've got any problems with the presentation, please put a note in the chat and Kira will interrupt me. I can't see the chat while I'm presenting, I'm sorry. Right, so what's CLS HASI? It's a wonderful program that's been a delight to research, because it's one of those programs that started more than 20 years ago as a community-based program to support people with severe mental illness to live and participate in the community in the way that they want to, which sounds like what you'd want all your mental health programs to do, but when it started, it was particularly revolutionary. And what's been exciting about evaluating and research is that because we've been able to demonstrate and prove its effectiveness, it's actually grown extensively over that time. So the parts of the program are that it provides to people in the program psychosocial support, tenancy support, clinical mental health services, and support to access secure housing in many different forms. One of the very difficult aspects of the program, and the reason why it's so effective, is that it's a statewide program and it's a partnership program. And any of you who have been involved in statewide partnerships knows that's a very difficult process to manage. It's funded by New South Wales Ministry of Health, but then it's delivered locally by the local health district mental health services in partnership with specialist mental health community managed organisations known as CMOs. So those are the non-government organisations that are contracted by the state government to support people to live in the housing of their choice. It's also, though, in partnership with New South Wales Department of Communities and Justice, which has been particularly important because of many of these people have contact across many parts of the state government. And the final partnership is with community housing providers who provide social housing for those who access that part of the service system. The evaluation aims then were usual evaluation focus. One, what worked well and what were the opportunities to improve CLS HASI. So this was an evaluation over, this latest one was over 3 years. So using the evaluation itself to help inform change. What impact did it have on consumers and trying to achieve the program objectives? And then particularly important for demonstrating change and future investment, was the program cost effective in terms of people's quality of life and cost modelling on their hours of support. The evaluation approach, because it's a large evaluation, was mixed methods, where we were able to look at the documents about the program, conduct interviews with people involved in the program, starting with the people who are supported, right through to the providers, the on-the-ground workers, and those that are thinking about policy and linkages. And the very ambitious part of this mixed method was data linkage, where we were able to link data from many different sources for the many people in the program, so over 5,000 consumers. That data, both the interview data and the linked data, was data over time, so it was from before they entered the program, during the program, and for some of them when they left the program. And also in-depth work in 3 local health districts in 2018 and 2019. So just thinking most broadly about what was the reach of this program, as I said, there were over 5,000 people in the program from 2015 to 2019, which was the main focus of our data. And during that time, the average length of time that each person was in the program was nearly 11 months. So some people were in for a much shorter time and some for a much longer time. And generally the program is working well. It's achieving its goals and it's cost effective. And that's what we're going to be talking about today. And most importantly, most people really like being in the program. For those of you who are researchers or in the service system, you'll know that's a pretty amazing thing to be able to say. And I'm going to hand over now to Peri to put a bit of flesh on those outcomes.
Okay, so I'm going to talk about consumer outcomes in particular, but it's based on the data that we got from the 111 interviews, which, as Karen said, were from service users, their family and carers, the service providers, and also some key statewide stakeholders. So first and foremost here, people reported that the program actually was good for consumers or service users' well-being. It made them more positive about their life. And we're also going to talk about physical health in a minute, but people became more engaged, more active, and just like had a lot more hope. There's a quote here that says, I think positive a lot more than I used to. My HASI work has got me thinking positive. If something's negative, get out the back, cut a tree, get out, run around with your dog, get that thought out of your head. And I do that one out of three times now, as I never did before. What I love about that quote is that only thinks positive 1 out of 3 times, but it's way better than what they were doing before, which I think in itself is a positive outlook on thinking positive. So there were also, and Fred will talk about this more later, measurable mental health and hospital improvements, which Fred will talk about. So there were, with that change in thinking positive, it actually improved people's mental health as well. Housing was also an important aim of the program, and a lot of people have been supported through the CLS HASI program to obtain housing. But probably even more importantly, to maintain housing. So that might be anything from, getting in there and helping somebody clean up before they come around to do an inspection, to helping them live with their neighbours, to negotiating a rent increase that they can't afford. So this person here says, yeah, help me with forms. I got a house straight away within 2 months with HASI, and we've been there now for 9 years. It's pretty cool. So in terms of the quantitative data, about 28% of consumers moved into a housing wait list or obtained housing after entering CLS HASI. So it does make a difference being in the program. A lot of people don't know how to get on a housing list or obtain social housing or obtain a rental that they can afford. And consumers had an average of wait time of 9.7 months, which was substantially less than general wait times. So again, it's because of that advocacy that can happen within CLS HASI programs. Also, there is a marked improvement. People reported a marked improvement in a relationship and the connections between people that have a lived experience of mental illness and their families. Often, people with a lived experience of mental illness, sort of ties break down because of behaviour and emotional issues and so on, and sometimes socioeconomic issues as well. And so it's a really important part of this program is actually helping people reconnect and make those connections when it's safe to do so. So the quote here says, they had mine and my son's relationship as something of importance, and they helped foster that. They used to pick me and my son up one afternoon a week to spend time together. And then they'd take my son back out of town to where he was living at the time. That meant a lot to me, because also a lot of, like this particular person, a lot of people have had their children removed from their care. And so helping them make those reconnections in safe ways with their children is important as well. Talk a little bit about social in terms, because these all come back to wellbeing as well. So being able to make those connections back to your family, being able to find a safe place to live where you can live for 9 years and know that that's your home, and also they all come back to that wellbeing. So being able to connect socially is important for wellbeing, to be able to do something meaningful in your life. And the program the program aims to work with people to help them find meaningful things to do and help them to engage in their community in ways that are meaningful to them. So this person talks about, my support worker used to come into Coles with me because I can't go in. I'm in no mood with crowds anymore, which I I used to be a social butterfly, but now I can have panic attacks while walking around shopping centres or crowds. I just got to the stage now where I can walk into a shopping centre with my support worker. So it's another thing, they walk with people. So it's a nice quote because it's actually is walking with somebody literally, but they walk where people are at and help them move on so they can walk by themselves. And again, the work, which is another type of community engagement, really important goal for many people. And again, it might be, first of all, you help them be able to get to the shopping centre, and then down the track, start working towards work or volunteering or education. I got a job when I was with CLS HASI provider, and that's a job in a factory. I've still got the job. How long have I been working there for? About 2 years. Oh, I enjoy it. It's always good. I'm doing something with my time. So important to be able to do something with your time that you see as meaningful. We did find that only a few consumers participated in learning and work in this study. But again, it's because often when they're in this program, they're at the stage where they're just learning how to get back into society in the first place. So it's a stage process. Physical health, there's quite a few examples where physical health improved. But there were some mixed results, mainly because sometimes people might have been in situations where they're institutionalized in hospital or in incarceration, where they didn't have a lot of choice around food choices and drinking soft drink and so on. And so it might take a little while for them to work out what the healthy choices are, as it does for all of us, I think. But there is a lot of program support around shopping and cooking and physical activity and medical appointments, which help people with their physical health. And in terms of criminal justice contact, there's quite new changes within the program to get more people from the criminal justice system into the program, particularly the CLS program. And I'm not quite sure what that means. They're new charges. And sorry, I should have read the sentence before I started talking. I can't recall what that means. Karen, do you know what that means?
So this was a huge achievement in that there were almost no criminal justice charges or criminal community corrections orders.
So it's similar to the hospitalisation we talked about on the other page. Sorry, I thought we'd already covered that. Okay, so in some of the process findings that we found that really help for these outcomes is that there had been really the partnerships between the community managed organisations and New South Wales Health LHDs generally worked well. They had a partnership right from referral through to supporting these people, which were often seeing both health services as well as the CLS HASI services. We did find that most referrals were from public mental health services. And so there might be some work to do there in terms of, people being able to refer from other spaces, because not everybody is lucky enough to, or lucky or unlucky enough to be in a public mental health service. And there is a lot of improvement to be done. That's what I thought that other quote was about, in terms of the referral pathways from corrective services, because there's a lot more scope there for that. So people there being supported. We found that CMO like community managed organisation staff were generally well trained and suitable, and they had good workplace support. We also found though that some CMOs appeared to underutilise some specific expertise of staff who are Aboriginal, culturally diverse, or had lived experience of mental illness. So they might have staff in their team that sort of identify in one of these groups, but they didn't necessarily have a different job description. So there's probably a lot more scope for those people to work specifically with clients that also identify to run particular programs, to raise awareness, and also to provide advice to other staff when we're talking about those things.
Thanks, Peri. So we might just hand over to Gianfranco now. Is there anything else you wanted to say on this one, Gianfranco, before we go to the next?
No, thank you, Karen. I think Peri has touched on the issues. So good afternoon, everyone. I'll continue reporting on the findings concerning the process element of the evaluation. In this slide, we will talk about the findings regarding the priority groups, which are people living in social housing and people living in boarding houses, people leaving prison or serving community-based detention orders, First Nation peoples and refugees. These were the priority groups. We'll talk also about findings concerning families and carers and relationships with other programs such as the National Disability Insurance Scheme and DIS, and factors affecting timely exit from the program. This is a short summary of the findings. There are many more concerning all these issues. So the evaluation found that program support did not seem to adjust much to the needs of priority groups. Now, this means primarily this was observed in the study sites, and in some cases, what the evaluation found is that there were weak links or lack of links with the cultural or community centers concerning, for example, First Nation people, refugees, and the other priority groups, or language services and so on. However, the evaluation found good practice examples concerning the program engaging with families and carers. With regard to the links with the external programs, such as the NDIS, the evaluation found that the links between the NDIS and the program were strengthening. This was evident throughout the 3 years of the evaluation. With regard to the barriers to timely exit, the evaluation found that often the main barriers were shortage of housing and support services, which slowed down the timely exit of the service users from the program. I think.
Okay, thanks very much, Gianfranco. We're just doing juggling here in my room.
That's all
right. Go, Fred.
Good afternoon, everyone. I'm Fred, and after all the COVID years, I've actually come in the old-fashioned way in person. So I'm on campus with Karen, and I'm sharing her video here. So just following on then from what the others have been saying, the evaluation as well had an economic component to look at the data and the program funding and how that's all performing. So I just wanted to start by saying that, as Karen opened by saying that the program's been going for a long time, there have also been previous evaluations, some of you might know. So this is actually the third evaluation. So we've had a chance to build on what's been done in the past, and most probably importantly is to extend it. So as Karen mentioned as well, this time we've got a lot more data, over 5,000 for all the data linkage, which adds to all the statistical significance of what I'm about to go through. Then also we've extended the data linkage. So there was data linkage in previous evaluations, but this time we've got more. We've got more sources. We've got the DCJ housing. We've got corrective services, and also on the CLS HASI minimum data set, the MDS. The ministry have been doing a lot of work over the last few years to actually introduce a new version. So it was only for the last part of the evaluation that we actually had some more content that wasn't available previously with this new MDS. And we also worked on some other in the background validation to cross-check all of these sources of data all come together. What we realized when we started looking at it, there's a lot of movement across the programs. People change locations, they pop in and out at different points. And when we started looking at the data, we realized that that's an important step to go through and just identify that which people have a particular sort of clean episode that we can assess. So we did some of that extended work. And then this all feeds into the economic modelling. So in this one, when the ministry put out the spec, they actually planted a note in there to say we'd also invite some innovative methods. And as it turned out, there were a couple of things that we could put into it. And one of them, this K10, like improving well-being or quality of life, or whatever we want to refer to it, as part of the collections for HASI, the K10 is one of those items. And as it turned out, in recent years, there's been some bridging work where we can actually leverage that and cross that over into a widely comparable measure, which is this quality adjusted life here. So we also did that. I'll talk more in a moment. And the modelling also, because of all these different data sets and all the variation, as we would expect, there's a big variation in people's outcomes and the changes in the hospital pathway. So when you put all this together, there's a big combined variation, and this modelling helped us to assess all of that in one go, which is sort of the only way we can look at that. So thanks, Karen. So firstly, just on these outcomes, we've just selected a couple of examples. For those of you that have seen the report, all 500 pages of it, there's plenty more there to go through. But this one, just starting on the K10. So on the right, you can see there's a graphic there of the dotted line halfway across is separating the before and the during. So you can see that the K10 is a score that when it goes down, that's a good result. So in this case, we can see there was a statistically significant decrease when consumers joined across the board, and that continued into the following year. So a very positive looking outcome there. There was a similar graphic for the HONOS scores, statistically significant, as I was saying, because we had more in the study group. This is all more, adds weight to the findings, consistent with the previous evaluation, but adds weight. And additionally, what we looked at as well is that the outcomes were clinically meaningful. Now, that's not to say they were run by clinicians. These are self-reported measures, and we're not suggesting this was a clinician assessment, but there are clinical meaningful ways to assess this, which we also did. So as it turned out, in addition to the main outcomes which you're seeing on that chart, about a third of all the consumers had a clinically meaningful, which is a more significant sort of improvement in this K10, which is a great outcome. So that's on the K10, and I didn't include the graphic, but just on the text below on the left then was about the community health service contact. Again, a very significant improvement. The number of contacts decreased, and as we see, they only decreased slightly in the first year, and this is almost as expected. The last evaluation actually found that the contacts increased in the first year, and this because of the lag is often, it's a good thing in many cases. It's just meaning that consumers are engaging in community services where they might not have been before. So this one's not clear cut, but it's fairly clear cut in the end to say 63% decline in the second year. It was a very substantial decline, which sort of reflects once consumers were more independent, they just didn't need that community contact. So that's a great outcome as well. Thanks, Karen. So now on the hospital side, with the mental health admissions, very substantial decreases, highly statistically significant, decrease of 44.8% in the first year, over 2 years, 74%. So you can see in the graphic on the right, very substantial declines. In addition to the number of admissions, the average number of days per admission was also very substantially down, which is another as important outcome, similar 74.8%. And the little dotted line in that graphic as well is just representing the involuntary hospitalizations, which it's a component obviously of the total in the black line, but you can see that that's had a similar, very significant decline in that group, and it's a fairly substantial number of admissions. So I'll cut on that one now. So it might be squeezed for time, catch up on some time. So moving then onto the cost effectiveness. So we look at the total cost of the program, and as it turns out, most of that, about 99% of that is funding that goes to the CMOs to actually deliver the service, but it also includes obviously the ministry that they oversee and manage the program and some other costs. But the most important thing with cost effectiveness is not about the costs, as I've said many times. It's about the outcomes. So all of the outcomes that we've been hearing about here are those that we leverage into the modelling. So the improved mental outcomes here, a big one is with the hospital admissions. So these ones tend to get a little bit more significance because they're visible and they're easy to quantify, and we have good data on them. That's a substantial cost offset. So those points on the left, the decreased hospitalizations and the length of stay, and the reduced community mental health services. They then get taken out of their cost offsets on the cost effectiveness work. And also, as I started by saying, this bridge that we made from the K10 scores, which is a part of the routine reporting for the program, great that it can be used. It's there, it's available, just so we can leverage that. And that gives us an indicator that is also used in the modelling for the quality of life. So what's been shown on the right-hand side, it's just different timeframes. So commonly, we probably look at 5 years as a fairly typical and what would seem like a good timeframe for HASI, because we know the average consumer was in the program for around 10 months. Some of them were there for quite a bit longer. So, and then they have a sustained outcome pathway beyond that. So looking at it in shorter timeframes is not so common. More common would be to look at it in a longer time frame, and it would have even more offsets and be even more cost effective. But looking at the 5-year starting point, which was the base case, it was already highly cost effective. So it's sort of almost 98.4% likelihood that it was cost effective at 5 years. So I sort of focused on the earlier ones to test that. And this was also related to the Productivity Commission did some work in the last couple of years and did a very detailed assessment of mental health services, community mental health services. And they use an assumption to say, because of all the variation in outcomes that I'm talking about, they just say, in that case, we'll only look at 1 year of time frame and just discount everything else. And they note themselves that is highly conservative, too conservative by far, it would seem. But that's why I've just included the 1 year as a super conservative starting point. And there we can see that it's almost cost effective at that point. There's 45% estimated likelihood, and the 2 year point that increases. So this is just establishing that the modelling lets us see that time frame, and it's sort of important to get a feel for that, because in the end there still is some uncertainty. But what we can conclude from that is to say that even if we used our conservative assumptions, and even if we looked at it in different timeframes, it might just mean that the program is more cost effective, year 2 or 3, and certainly by 5. So great looking outcomes. So my last slide, thanks, Karen. So this one, just on that, continuing on that 5-year timeframe, which was the last bar, the highly cost effective bar on the previous slide. This is now looking at, this is what we see when we come from the modelling, and it's not meant to be just a mysterious bunch of dots on the chart, but what it does show us is that after it takes all that linkage gets put together from all of those sources, and there's all the different variations and from all the different people, and they're all different distributions, all those things get put in. We run it, it just gives a pathway of where different people might come out on their outcomes, their different outcomes. So what's this showing us overall is that the left-hand cluster that's a bit more grouped together, that's before the program. And there you can, it's sort of on the left, it's about 185,000. This is over 5 years of average service use and hospitalizations and everything combined for this group. And then the group, the dots further to the right is actually once consumers have entered the program. We can see there that it's much higher variation, which is exactly as we'd expect. But overall, if we drew a line through the middle of that, you can see that that's around, it's less than 100,000. In fact, it's 99,000. So what this is saying is that on average, there's about an $86,000 saving, you could say, a reduced cost when the program, when consumers are in the program, and that's offsetting the cost of the program. So you start at 185, we add the cost of the program, which is 13,000 or whatever it was. It's been a couple of years already, and then including that addition, the offset is 86, which is a very unusual. The main reason I'm presenting this is that that's highly unusual. Usually, when you have a new program or a new intervention, you have something that you're adding and it has an increased cost. So most often you would have a higher cost to the business as usual, the previous model, and then you start to look at the outcome, which outcome's better for that increased cost. But here there's a lower cost to start with, so it's a very very positive, cost-effective result. And then just to finish, the last 2 points are that from the K10, we could also say that in addition to the cost saving, there was actually a statistically significant K10 result, which converts and is estimated to be this 0.25 of quality adjusted life year. I know it might sound like some mysterious measure, but it's still significant because it is a well-being metric. It's a widely established and recognised measure. So on top of the cost saving, the program is generating a measurable standard quality of life outcome, which is great. And the very final point is that that's just pretty unusual. So I just wanted to underline that to say, usually these types of modelling are presented to say you have a higher cost, the next program is incrementally higher cost again, and then you have two outcomes and you're comparing those ratios. But in this case, there was the clear cost saving to start with, and then a positive. So in effect, it's a negative cost saving, which is abstract, so it's not presented. They just refer to it as cost saving, but it's a highly positive outcome. Thank you.
So there's nothing like a very enthusiastic economist in your office to promote a good program and a good evaluation.
I'm the health economist. We're all like this.
Health economist. Thank you, Fred. Needless to say, there were challenges for CLS HASI and for similar programs, and I think it's very important for us to highlight those, and hopefully some of you will pick these up in the discussion. There are ongoing challenges which the program's aware of and that they're trying to address. The first is it's very hard, as I mentioned at the beginning, to first make and then keep going local and state level partnerships beyond the frontline delivery partners. So as Gianfranco emphasised, the partnership between the local health districts and the community managed organisations by and large was strong and getting stronger. But in order for this sort of program to be effective, we need lots of partnerships. So for example, we need partnerships into employment services, into housing services, into disability services. And those partnerships, the effectiveness of those partnerships are critical first for the diversity of referrals into the program. So for example, there was a priority about, as Gianfranco said, about including people leaving the criminal justice system or leaving very marginal housing situations or homelessness. And yet it was very difficult to incorporate that type of referral into the program because of the investment that's needed into those sort of partnerships. This also then has an implication for the third point in terms of responsiveness to the needs of some priority groups. So partly that's about the referrals that we've mentioned, but also it's about when people are in the program, particularly as Peri gave the example of people from Aboriginal and Torres Strait Islander background, making sure that the workers understand that the same is not the same as equal or equitable, that we actually need to think about the individual, the person's needs, and think about their personal situation, but also their community expectations in order to meet those needs. I think one of the great innovations of this program is that there's a lot of flexibility for the community managed organisations providing support to people to live in their own home. But that flexibility requires discretion and requires a lot of adaptation, both from the frontline workers, but also their employers, and this has implications for the sustainability of those organisations. And so that's a very difficult task, and an ongoing one that I think that the providers in this program will continue to talk about. In summary then, the implications for CLS HASI and for similar programs, because this is a program that's been replicated across Australia and in other countries, is that there were very important success factors that were highlighted in this very in-depth evaluation. The first being the strong local partnerships, which required structures and investment of time at a professional level, at a management level, and at a frontline level. And secondly, that it needed to be, and increasingly was, person-centered and flexible in terms of thinking what it is that this person needs now and what do they want next. And it was very encouraging to see that increased focus on the person themselves making those choices and being supported to make those choices. One of the interesting contextual situations for this evaluation that wasn't available in the earlier two was that we now have the National Disability Insurance Scheme. And when we started this evaluation, that was really in its infancy. By now, it's established as part of the system. There are many problems in integrating the two parts of the system, particularly for people with chronic mental health. But it's increasingly also being seen as an opportunity for a program like CLS HASI to be able to work in partnership with NDIS providers, making referrals into the program, working during the program, and helping people exit the program to sustainable housing and support in the future. So we'll leave it there in terms of what we'd like to present today, but as Fred mentioned, there's an enormous amount of written information about this, including accessible easy read versions and video from one of the previous evaluations of HASI. So we certainly encourage you to look at those other resources, but now we're very keen to hear your comments and questions and discussions about what we've presented today. Thank you.
Thank you, Karen. That was wonderful and lovely to hear from all four of you. And yeah, Fred, your enthusiasm was to be able to present figures like that must feel pretty good when you work on an evaluation of this size for that length of time. So there's actually quite a few questions. Well, there's two questions that have come through on the chat, one from Rebecca Reeve and from Bei Lu. And those are concerning the threshold for being considered cost effective. What is that? So if either of you would like to ask that question, or if you're happy just for Fred to respond, you feel free to turn on your camera or turn on your unmute yourself and ask the question directly if you wish. But Fred, I'm assuming you can see those questions.
Yeah, so just the cost to quit.
Yes, Rebecca.
Yeah, so the
Hi,
first one.
I just asked a question about the cost-effective threshold, because I can see that it's cost-effective because it's cost-saving. But in the slide where you talked about the probability of being cost-effective, like was there a particular threshold you were using to decide?
I used 50,000, but I also used 0. So there's another sort of way I was going to position that, because also, I know, Rebecca, you'll be familiar with it, but the Productivity Commission work more recently, because there's no real consensus on this exact metric, they sort of had some bands, and they had 70,000 was quite cost effective, 50,000 was very, and below 20,000 or whatever they said was highly cost effective. So on that spectrum, because it was sort of even further to the left of that, I've sort of concluded that it is highly cost effective. But when I did the modelling, I used a 50,000 just as a baseline, just to answer the question. Thanks, Rebecca.
And then the next question, there's a question from Bei Lu. Apologies if I'm mispronouncing that. What is the cost per client to enter this program?
Well, the cost per client, well, to enter the program, so it's not really a cost of entry, but it's an average cost of once you're in. The report includes some other figures on this one as well. So the average cost, because the costs are tailored to need, they obviously vary depending on how much support consumers receive. So the average, again, from memory, I should remember every figure. It's already a couple of years since we did the main work, but it's around 13,000, or I know on average. But that was broken down, and it's highly variable. So we split them just into 3 bands, and we had low, medium, and higher cost. So the average cost was about 13,000, as I said. The high cost was up as high as almost 200,000, but there were very few in that category, and the lower cost was a few thousand or so per consumer. So I hope that answers that question. There's a lot more in the report on that as well. I could go on.
All right, I'll read out a few. There are a few more questions coming in, but if anybody has asked a question and Fred's responded and you want more clarity, please feel free to jump in. I'm just going to move to Caroline's question now, though. What changes to the program have resulted from the evaluation to date?
So Peri, did you want to address that, or Gianfranco? Peri and Gianfranco went to the site, so they observed the differences.
Peri, you want to?
Yeah, so definitely over, like I wasn't involved in the earlier evaluations, but I've read the reports and so on. And also staff and consumers are often able to tell us if they've been in a long time. So one of the things is that have a much greater understanding of recovery in the mental health sense, and also trauma-informed approaches and person-centered approaches. Yeah, and much more flexibility, I think, than they did earlier. So it was very much about choice and control for people. So they all the centres had like ways of, actually, as Karen said during the thing, they had ways of helping people, facilitating choice really, and helping people set goals. So as I said in the presentation, the goal might be quite small to start with, but then sort of build up to bigger goals. They met people where they were at. Do you want to say anything else, Gianfranco?
No, I agree with you, and the change also in the relationships with NDIS.
Oh yes.
Strengthening links, and also with some community First Nation people centers and organizations. In some cases, those links strengthened over the life of our evaluation.
Yeah.
So I think it's important to acknowledge, of course, we can't say what changes were because of the research, but I think one of the benefits of doing formative research like this is that we're listening to people, and within our research team we have lived experience researchers who are demonstrating the benefit of listening to people through the presence of people who have experience of this type of service system. And so in a research or evaluation framework, we're then feeding back that information to them in a way that they can use themselves to bring about change, either at the local level or at a more system level. And so one of the points that Peri highlighted today was about the employment of Aboriginal and Torres Strait Islander peer workers or support workers, both within the community managed organisations and in the local health districts. Now, that's not an idea that came from the evaluation, but what did come from the evaluation was that we were able to say where it was working well and how other areas might be able to learn from that. And so I think at a micro level that's very important. One of the other questions that's put here is in the chat has been what impact has this had on funding of the programs? And I think this is this program is an example of where the ministry has been very strategic right from the start 20 years ago, with a very small pilot program of 100 people, being very particular about measuring the economic costs and benefits alongside the qualitative stories and particularly the formative evaluation. And so as you can see from the data that we've presented today, because that's now in an evidence structure that the ministry can use both locally but also centrally to making a pitch to Ministry of Health and then Treasury, the program has extended from 100 people to many thousands of people. And that would not have happened if the ministry could not prove that this was improving the quality of lives of people and improving the efficiency of the system, and in the economic terms is cost effective. So it's one of the reasons why we're so enthusiastic about it. I mean, it was lots of agony trying to get linked data to make this work, and to make times and make methods that were accessible to people. But in the end, that's the reason for doing it, is because the evidence then can put forward the arguments as to what small changes and big changes are needed.
Thank you, Karen. There's another question here from Val Fell, which I'll read out in a moment. And there's also another one after that that I think just came directly to me, not to everybody. And I'll read that out afterwards, just in case you can't see that. So the one from Val Fell is, did you include any persons with younger onset dementia in your studies?
Peri, can you answer that?
I don't recall that specifically. I've done other research where there's been younger people with onset dementia, but they've already been in aged care. No, I don't recall. Do you recall anyone, Gianfranco?
No, not this.
We often don't. Yeah, we don't spend a lot of time, or a lot of we didn't really talk about diagnosis so much. We talked about functioning and you know how things were going for them in their life, rather than what their diagnosis was. A lot of people volunteered diagnosis, but there wasn't. Yeah.
And the services they were receiving, so not so much their personal history as in terms of mental illness.
Okay. That's a really interesting question, Val, because I think, as you can see from the way that we've presented the results, this approach is relevant to people with complex needs for whatever reason. Yeah. These particular projects are about people with chronic mental health, but equally, it'll be interesting to hear. I can see you've got your mute off. Thank you. So I'd love to hear from you about your views on that, about its relevance for younger onset dementia.
Well, younger onset dementia are not included in my aged care.
Yeah. Yes, and that's a problem, isn't it? Because
they're not in my aged care. So therefore, I know that Dementia Australia does some things with them, but they're not, they just don't come under, my aged care because they're under 65. So they can come under NDIS, but they can't come under my aged care. And so there are programs, I mean, I assume that there were, well, mental health people come under NDIS as well, but there's no reason why, dementia is a mental health problem, really.
Yeah. And definitely about the people that I've talked to in another evaluation project on a New South Wales health program called Pathways Community Living.
Yeah.
That often people with younger onset dementia do have mental health challenges as well, as you would imagine. And so, and I guess maybe that's also, like we talked about, that there is quite a lot of opportunity for them to increase their referral pathways where they get referrals from. So it might be that someone has a mental illness, a challenge, a mental health challenge, along with their onset dementia, but if they're not actually in the mental health, LHD mental health world, they might not.
Yeah, because I mean, people with delusions can often, really have dementia.
Yeah.
And I know I've seen the various, I've done the mental health first aid thing, and I can see sort of certain similarities.
Thank you. And so there's one question here. I don't know if anyone else can see it because I think it came directly to me rather than to the chat in general. But it's from Carolyn asking, did the listening cover residents in assisted boarding houses or general boarding houses only? Sorry, could you repeat the question? And Carolyn, if you feel like unmuting yourself, you're welcome to ask directly. Otherwise, I'll read it out. All right, I'll go. So did the listening cover residents in assisted boarding houses or general boarding houses only?
So you mean the listening, like who we interviewed, who we spoke to?
I'm guessing that's, yeah.
Yeah. So we definitely went to houses or to places where people were in assisted accommodation or supported accommodation, I think we're talking about. I can't remember if they were boarding houses or not. We mostly talked to people within the organisation itself. So yeah, and some people definitely lived in a boarding house, and some people lived in supported accommodation. I can't recall whether or not they were supported boarding houses.
So Carolyn, I think your question is relevant at several levels. One is people from boarding houses or homelessness, so that's including both types of boarding houses that you're referring to, were priority groups for referral. But as we mentioned, referral from anywhere other than out of the mental health system was less successful. And so that is an area that the ministry is working on, both for this program, but for more generally in terms of how to make those partnerships more useful. Interestingly, the other area where boarding houses was relevant was for people who were leaving the program. And so leaving to a supported boarding house or an NDIS package in a boarding house was a way that people were exiting. And obviously that's not ideal in terms of stable housing, which is one of the goals of the program. And so it does remain, as Gianfranco emphasised in his presentation, it does remain a difficulty for the program as to how to assist people to leave the program, but leave with stable housing.
Thank you. We've got 2 minutes left. If we go to the deadline. Does anyone have any final questions? Feel free to raise your hand or unmute yourself or ask a final question, or I've got one final question actually. I'm just curious about demand for the program. Is there capacity to meet demand?
Peri?
No. You know, we ask one thing at the end. We say, if there's one thing you'd like to change about this program, 99.9% of people say more of it. It's an amazing program, and and like it's frustrating because we know from Fred's presentation how much money it can save.
Well, look, that's probably
thank you very much for the presentation.
Yeah, well, okay. Thank you, everybody. Listen, we're going to wrap up here. So thank you, everybody, for joining today. And thank you to our presenters for a wonderful presentation, and to everybody for all their questions. And then, sorry, somebody's asked, actually, there's a few more questions that have just come in. Final questions. What's a clinic? Oh, my gosh. Hang on. What is a clinically meaningful K10 change? That was one from Rebecca Reeve. That might have to be this time. Yeah, okay, it's just that one. So, Fred.
What was the clinically meaningful measure?
What's a clinically meaningful K10 change?
Well, K10, it was the same for all of those. It's effect size. So it was based on, it's Cohen's D. It's standard effect size on these measures. But Rebecca, I can send you the details. It's in the endless appendices as well. So it's Cohen's D. Yeah.
Thank you. That'd be great.
That's great. All right. Thank you so much. And look, we've had, I've just from the chat earlier, we've got people from the UK. Well, one person from the UK, from Perth, ACT, and who knows where else. So from all around the world. So thank you, everybody, for joining us today. Much appreciated. Our next SPOC CSRH presentation is on the 4th of April with Associate Professor Sarah Calabresi, who's a visiting academic from George Washington University in Washington, DC, who will be presenting on addressing inequities and enhancing patient-provider communication in the era of HIV biomedical prevention. So we hope you can all join us for that. But thank you all, and till next time. Bye-bye.